I like home feed.
I don't think there's anything to.
I don't have any girls, so. Fourth stage, first 4 hours after birth. So we know what happens to the fundus, right? We know what the lochia looks like. It goes from red, pink, white, rubra, serosa, alba. When should lochia stop? Well, it should stop. It's about 10 to 14 days. Like if you talk to your patient, it's been 27 days, and you say, well, when did it stop? Well, it really hasn't. Well, that ain't right. It's like a period. It should stop. Stop. Some people will say, oh, it never really stopped. I just got my regular period. That probably isn't so. They probably have a reason that they're still bleeding and it's not normal. Perineum checks. I think we covered all this in postpartum, bladder, all that stuff. Baby vital signs, of course, color, mucus. You know, some babies have a lot of mucus. Sometimes they require suctioning, and sometimes they don't. Behavior of the baby is kind of important because it's a really good time for bonding. Because babies are like bright-eyed and bushy-tailed right after delivery, whereas later on they're going to take a nap and they're going to wake up in about 24 hours, maybe 36 hours. Now that's too long for them to sleep and not eat, so we're going to be waking them up. The parents will be very frustrated. We try to be supportive and help them wake the baby up and get the baby to feed and reassure them because we all know it's true. They are going to wake up, aren't they? And they're going to be awake a lot and crying and you need to be changed and bed. Like, too much sleeping is not going to happen by the time they leave the hospital. So they just need our encouragement. But because they're so awake, it's a really good time to establish breastfeeding and to give the family time to bond. Yes.
So the mucus for the baby, if they're really mucusy, when they come into the office days later and the parents are like, they sound congested, that would be still having some of that mucus in there?
Well, it's probably in their nose though, right?
Yeah.
No, this is mucus from the lungs that probably just didn't get expelled. That's what the bulb syringe is for,
Right.
right? And you know, you put the bulb syringe, you know how to work it, depress it, put it in back here, not on the cheek, not on the gum, not on the tongue, we're putting the tube in the gum, right there, and then squirt it out and do it again. They don't like it. But you don't want to go straight back into their throat, because that'll cause them to gag and throw up, right? It would use, and kind of sneak in on the side. And you can do it in their nose too, they don't like that anymore. But in 3 to 4 days, they probably have some nasal congestion, I'm thinking.
Okay.
They should be not lung juicy anymore.
No. Okay.
I don't think so. Oh, and movements are important. Which extremity should your baby move? Yes, good one. All right, a lot on that chapter, a lot of questions on that chapter. Now, next. Okay. We need about 4 more days. You know what? It doesn't matter. Even in my regular class, I never. I talk too much.
16 and 17. Five minutes.
For real problem. We're down my battery. Okay, so the other chapter here is, there are 2 that I really wanted to do. Pain management for childbirth. I'm just going to have your notes. I don't think there are any major pages. There's just one thing I wanted you to see. You should watch this at home if you haven't seen it. Is it in your notes? Oh God, this is funny. This is how men react to labor pain. Google it, and if you want to have a little laugh. It's a couple, 2 different couples, and they put TENS units on the men, and they experience labor. And of course, they're all hot, you know, macho. By the end, they're like bent over. And so the physician said, you know, they're like, how far are we? The physician says you're like 1 centimeter down. They're like, oh my God, no. So it's kind of fun. Kind of fun. Anyway, they don't get any medication in their defense. I'll just have to post them and you can look at them, or I'll just have to talk over it. I just have to make a talk over it. I don't think I have one. But I'll tell you this, a lot of the pain management, other than giving them IV push medication, we as the nurse, don't do a lot of it. we're not giving anesthesia of any kind, whether it be general endotracheal, spinal, which your book calls subarachnoid, which is anatomically correct. But when I hear the word subarachnoid, I always associate that with a hemorrhage, like a stroke. It scares me. But it's a spinal. So we don't do those, but we assist and we monitor afterwards, right? So, that's what you'll hear me say when I do it. We don't do a lot of it, but it's our responsibility to monitor before, during, and after, make sure the patient's okay. But I'll just have to talk over it because it's just all I can do. But let's talk about this chapter because there's a couple of things I really want to make sure that we know. What time do we get out?
Two.
Oh, I can't remember. It's not good. Okay, so these are obstetric procedures in the intrapartum, so during the labor and birthing process. Some of them we've already touched on. As you look in the chapter, it may have rupture of membranes. But I've already told you how we rupture membranes. There's two ways. How's that? Artificial, with the little hook thing. I think there's a picture in your book. And we know the risk associated with rupture of membrane, which is
Infection.
after 24 hours. What's the immediate risk? Cord prolapse, cord compression, which means our first follow-up to rupture of membranes, regardless of whether it was the artificial or spontaneous, is what?
I think so.
Assess the fetal heart rate. If they're on a monitor, yeah. You're bad.
Yeah.
We weren't talking about you. I think I just called your name or something and then I'm looking. Okay, identify clinical, blah, blah, blah. So, first thing we're going to talk about is augmentation and induction of labor. So that you understand the difference. If someone were going to augment their breasts, what happens to their breasts? They get bigger. So if we're going to augment labor, what does it do? It gets bigger, kind of gets bigger. So that means it's not like, if you have a breast augmentation, you must have breasts of some kind. Whether you're even a man or a woman, you've got to have some kind of breast there, okay? Got to anatomically be made like that, okay? So in this case, if you're going to augment labor, you already have labor. We're just going to make it bigger and better. It's going to get faster and longer and stronger, okay? If we're going to induce you, do you have labor?
No.
Nope, none in sight. We're going to take you cold and get you warm and make you hot, okay? So those are the big differences. I do want you to know why we may do some of these procedures. And in this case, why do we induce patients? And there are 1, 2, 3, 4, 5 categories. 6, 5, 6, I don't know. So pregnancy issue, post-term. How many weeks is that according to your book? After 42 weeks. Megan, you were on it today. Rupture of membranes or at near term. Most women, about 80% of women, once their membranes rupture, they are in labor or are going to start labor. But there's a small number of them who rupture membranes and don't start labor. Well, we know within 24 hours their risk of infection increases, so we're going to induce them if they don't have labor. Okay? Then we have some issues with the fetus. Intrauterine growth restriction. Used to have a different name. It's no longer that. It's restriction. If you knew the old one, get rid of that. It means restriction. Intrauterine growth restriction. All that means is the fetus is not growing like it should. So we might find that first by doing our McDonald's measurements. We might find it on ultrasound that we have a woman who's 24 weeks and her fetus looks 22 weeks. We may not know why then or ever, but we know that this fetus is not growing. So we'll have to keep watching it to see if it ever catches up. Fetal death. It seems cruel, but when you have a fetal demise, the fetus has still got to be delivered. And if there are no contraindications to a vaginal delivery, 99% of the time, that's what they're going to go with. To do a surgical procedure on a patient who does not need a surgical procedure, meets no criteria, is a risk factor for the healthcare provider. Because if any kind of surgical complication or anesthesia complication results, their peers will say, well, they didn't need to do that in the first place. And eventually they'll find somebody who will say that. It might take a while, but they will. So fetal death is a reason for induction. If the mom is sick, okay? If mom is sick, so here's some problems with the fetus, IUGR and fetal death. If there are others, don't worry about them. These are the ones in the notes, the ones I want you to know. Maternal problems, mom is sick. She either has diabetes, hypertension, or both, renal disease or pulmonary disease, but she's sick. There's something she's not able now to be pregnant. All that extra fluid, just carrying around a fetus, whatever it is, we have to get the fetus out to save mom, because she's sick and she can't do it anymore. Because, Cornelius, where do we want to incubate babies? In those lovely like incubators in the NICU or in the uterus?
In the uterus.
In the uterus until it's no longer a good place to incubate. Okay, and that could be because there's a problem with the fetus or a problem with the mother. Then if there are complications for the mother, she could have from prolonged membranes, a chorioamnionitis. Ooh, that's a big word. And if we just function on the last 4 letters, what do we know it is? Inflammation. Inflammation, it could be infection of the what? Chorion. Of the chorion and the amnion. So this could be life-threatening to mom and baby. So we need to get the baby out so we can treat the mom, get the fetus out, treat the mom. So this is an inflammation or infection. The other one is an abruptio placenta. When does the placenta, I don't think that's spelled right. When does the placenta normally deliver? After the fetus. What if the placenta delivers before the fetus? Hey, right. We got a fetus not getting blood supply, okay? So that's an indication. And are there any complications of induction? Yes, there are. So willy-nilly induce people, everybody at 38, 39 weeks for the condition of, I'm tired of being pregnant? Not necessarily a good idea. Here are just 2 of the reasons. Increased risk of autism and fetal distress with meconium. Exactly what causes those are deep in the literature, but they are being written about. So these are 2 of the reasons that we say we don't want to just induce everybody because they're tired of being pregnant. Okay, which seems like a good reason, but it's really not. So I want you to be familiar with them. Lynn, I want you to be familiar with them. All the rest of you too. But Lynn had asked me a question a while back, and so I'm going to make sure that was part of the answer to the question. Okay, induction and augmentation of labor continue. How do we know when we can induce safely? Well, hospitals tell us we cannot induce a woman for labor prior to the 39th week unless she meets some of the criteria on the previous page of having problems with the fetus, problems with the pregnancy, problems with the mother. 39 weeks, because we used to induce a lot of people at 37 and a half, 38 weeks, and data collected by insurance companies revealed a startling finding in that those babies born late preterm were readmitted to the hospital at ginormously increased risk for feeding problems and therefore jaundice. Just because they looked like they weigh enough, they couldn't do what, Cornelius? What were they not doing? These preemie babies, what do they not do very coordinatedly? Suck and swallow. They might suck, which is why they can suck on a pacifier. But they don't suck, swallow, suck, swallow, suck, swallow, suck, swallow. They don't do that in a coordinated way. So they would not gain weight, they would be fluid deprived and end up being jaundiced. So the insurance company, being the nice, smart people they are, they said, you're not doing that anymore because we're not going to pay for it. If you don't do what's right, we're not paying you. So now, 39-week induction. When a healthcare provider calls and said, I want to schedule an induction, first words are, how many weeks is the client? And if she is less than 39 weeks, they have to have a reason. And if the reason doesn't fall in a very tight criteria, it will be reviewed by the director of the department, which is a healthcare provider, not a physician. So one way we know that it might be a good time is by doing something called Bishop scoring. As you notice, it's sort of like an NST scoring or an Epler scoring, and this is not what I'm going to ask you. I'm not going to ask you what a score of 3 on dilatation means. But just like on the biophysical profile, I said you should know the components. You should know the components of a Bishop score. Okay? and kind of what it means. So we're looking for dilatation. Obviously, we want them to be a little bit dilated already, because if they're closed, it's just not really a good sign. Effacement, we'd like for them to be a little bit effaced. Station, we'd like for them to be at least where we can feel them and not be laudable. Okay? Now, it doesn't matter if we got a bad uterus, a bad baby, or a bad mother. We don't care about Bishop's score. Don't get confused. This is an induction that's not medically necessary right now. Does that make sense? This is if we just want to induce them to get the baby out because they're tired of being pregnant and they want to have a due date of, July, whatever. Consistency. We don't want the cervix to be firm. In fact, it's really never firm, but we want it to be soft, obviously. The position refers to the cervix. When I put my fingers in the vagina, what do I need? Do I need a cervix? Or do I have to go way down here digging for a cervix? Or way up here digging? I want it to be like pointed like a cannon, right out the vagina. That's the most advantageous, because it means, it's part of being ready. So we take all of this score, and when they're about 8, then we know that they're good.
So 8 or higher is good, or 7 or higher?
All right, whatever you want. I said 8, you like 7?
Well, because in the book, it's 7 or higher in the thing, but then in the paragraph of the book, it says 8, like you just.
Put that on there. I really dislike that about this textbook. 8 is in my head. I'm not going to ask you, and I don't think NCLEX would ever ask you if it's a 7 or an 8. I think if they said we have a Bishop score of 0 or 2, or we have one of 12, I don't think they're ever going to tighten it like that at all, and I don't even know if they'll do a number. It might just say, I don't think they will, but
Okay.
we'll say 7 or 8. Okay?
That's clients review or practice will ask you
That type,
8, 7.
but that type, like they put 7 or 8, knowing that in some textbooks it says 7 and some it says 8.
That's the question I have. I don't know how it's that.
But was it that close to being abnormal or not?
Yeah,
Oh,
specifically an
on an APGAR. Well, I'd have to see the questions, but. All right, well, 7 or 8, know it. We're gonna go with that. I want you to know that now. Score of 7 or 8 is normal on Bishop's. Now, that doesn't mean they're not gonna induce. I'll tell you, I think my daughter-in-law got a 3. But her high-risk OB said, induce her. And so the OB said, okay. I have that in writing, and she double-checked it too to make sure it was in writing. She pulled up that computer. Let me see exactly what he wrote. She was looking for her CYA too. So how do we induce labor? There are 3 different ways that we can induce the labor. Surgical, which sounds like a big dramatic procedure. It's really just rupturing the membrane, amniotomy, okay? But your book categorizes it as surgical. We can also do it medically by ripening the cervix with some medication, prostaglandins, which I'll show you a picture of in just a moment. We can also do it mechanically by sticking things in the cervix and make it open up. By golly, I'm not going to give you some medicine, we're just going to stick it in there and you got no choice but to open it. So surgical, medical, and mechanical. So the surgical technique is the amni-hook, and here's a picture of the amni-hook. You see that little sharp piece right there. Again, guided by the fingers, snip that bag of water, and the bag of water breaks, and what data will we collect and document with the water? Good, taco. Or coat. And also, about the fetus, we will document heart rate. Because when the water breaks, the cord can come down and be compressed or fall out, okay? Induction technique medically, we'll use Pitocin. So here's the idea. This right here might start labor. This is an induction technique. And the reason that it would work is because it causes the fetus to descend and causes pressure on the cervix. It also causes prostaglandins to be released, and therefore they will irritate the uterus and contract. That's how the surgical works. The fetus pumps down the pressure on the cervix. Also, the rupture of the bag of water will cause release of prostaglandins. So then we have the medical technique. But before we do that, let's go to mechanical, because it's easier. I spend more time on the other. So mechanical, there are a couple of different ways we can do it. Again, we're kind of forcing our way through the door, literally. This is called a laminaria, and it is hard as a rock. It's made of seaweed though, or let's see if it tells us what it's made of. Well, it's osmotic, but it really is seaweed. You just have to trust me. And what happens is we stick it into the cervix, and the cervix is moist. It's mucousy and watery in there. And so it causes that laminaria to swell. And so it pushes open the cervix. A little bit anyway, okay? When it does that, prostaglandins will be released, and maybe labor will begin. The other thing we can do is take a cervical ripening balloon. It looks kind of like a Foley, but with two balloons on it to anchor. One goes on the inside of the uterus, so by the internal opening of the cervix, and the other one goes here by the external opening of the cervix. And what it really does is it separates the bag of waters, causing release of prostaglandins. Are you seeing a common theme here? Prostaglandin, prostaglandin, prostaglandin. We either give them the prostaglandin, or we make prostaglandins, or happen, we release them some way. So that's how it works. The only thing in the actual cervix itself is the teeny little catheter. Okay, so this you have to be dilated a little bit to put in, but the real thing is the pressure that it causes from both sides, but the separation that this balloon right here causes between the bag of waters and the side of the uterus releases prostaglandins. Okay, so that's mechanical. Now, we have medical, and that's all about Pitocin. Danger, 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 danger. So we use IV Pitocin, and usually the night before a scheduled induction, the patient will come into the hospital and have prostaglandins inserted into either their vagina or cervix. There are a few different ways you can do it. This is one called Cervidil. It's like a little string, flat piece of, almost like a flat piece of dental floss. And they tuck it right up underneath the cervix. And those prostaglandins will cause the uterus to be irritable and contractile. Sometimes that's all you need, and boom, they go into labor. But if not, hopefully it'll get the cervix ready so that the next morning they'll start Pitocin. We use Pitocin to augment labor. We use Pitocin to induce labor. Pitocin is a very, very dangerous drug. I forgot my notebook for some reason, but Pitocin is on a list from the Federal Drug Administration that contains, I believe, 10 other medications that are called high alert drugs. And these are drugs that have been known to cause severe complications in patients. Of all the drugs on the market, there are 11, and this is one of them. I hope that impresses upon you how serious it is. Also in that same article, it tells us that 50% of all lawsuits that end in settlement are related to OB care. OB, very litigious group of people, okay? Because you get a sick or dead baby, sick or dead mom, I mean, all you gotta do is show a picture or say, here's a blank picture, there is no baby, there is no mother, and people start pulling out their checkbook, okay? So, it's very litigious. Of those 50% of lawsuits that end in a settlement, and this is documented, 50% of those are related to the Pitocin administration. Okay, that's big, big. Why? Because if you augment, stimulate too much labor, and the contractions come too close together, too strong, lasting too long, and the uterus never relaxes and fills back with blood, therefore giving blood and oxygen to the fetus, you have fetal distress, problems, hypoxia, anoxia, brain damage, bad outcomes. Okay? Or you have the problem where the mom, because here's the other thing, Pitocin is has an anti-diuretic effect. If you have a diuretic effect, what does that make you do? It makes you void, makes you pee, it absorbs more water from the vascular system, making more urine, right? This is an anti-diuretic. So it stops your body, so you're retaining fluid all the time you're doing Pitocin. Now, we know that with every regular contraction, what happens to the blood in the uterus during a contraction? It goes out. Now we're pushing out 300 to 500 mLs of blood into the vascular system, into a system that is already retaining excess fluid. So we have the possibility of fluid overload in cardiovascular events for the mother. This is a powerful drug. Not that it should not be used, but it should be used following safety protocols. And that includes the healthcare provider should be in the building. That is not always the case. They're supposed to be in the building, not down the street, not across the street in their office. They're supposed to be in-house. A lot of corners cut there. If you work in L&D, I would definitely subtract. Just saying.